The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello, George, and it's Tuesday again. Pleasure to see you one more time.
Yeah, twice in one day, 3 times in one day, counting the coaching classes. It's like a triple bravo. Today we have a very great physician, Dr. Mary Ann Jackson, and her topic is going to be about infectious diseases, long gone, measles and varicella, to be exact. And we do have some experience with that.
I first had the pleasure to meet Dr. Jackson at the Miami Postgraduate CME in 2020, right before COVID. And boy, was she full of insight, like an oracle. We had finally the pleasure to once again meet this past March in Miami again at the Children's CME. She's a phenomenal woman, a phenomenal pediatrician, infectious disease specialist, vaccinologist, dean, and educator. And now I also find out that she is a co-fellow of one of the people that I admire most on this earth, Dr. Carla Odio, and one of my dear mentors. I am so delighted to have her on the show to record the horrors of the classic pediatric illnesses that are no longer with us, thanks to the work she has done and the work of community pediatricians that vaccinate one child at a time. Welcome, Dr. Jackson. Thank you so much for being with us.
Thanks, Dr. Bravo. Thanks, Dr. Rugu, for having me.
I'm going to start with asking you, George, Dr. Jackson, why did you become a pediatrician and infectious disease specialist?
My path to becoming a pediatric infectious disease specialist certainly started during my medical school years when, remember, back when I trained, 80% of children with childhood cancer died. And as a medical student, what I remembered is they died of infections or they died of complications of their cancer, meaning they died with bleeding, dyscrasias of such. What I realized at that time is maybe I had a chance to impact on their survival by creating a path to treating some of the infections like aspergillosis that were killing these children. So as I decided on a path from pediatrics at Cincinnati Children's Hospital, it's a very interesting fact that I think you'll enjoy. So when I went to Cincinnati Children's, there was no infectious disease faculty there. And in fact, Dr. George McCracken and Dr. John Nelson came about every 3 to 6 months to provide consultations. And as the intern who was interested in infectious diseases, I would prepare the cases to discuss with them. So along came Dr. McCracken and Dr. Nelson on a regular basis. I shared our cases. I learned more knowledge. I got interested in the pharmacokinetics and pharmacodynamics of drugs that we use to treat infections. And I became an enthusiastic learner of communicable diseases in childhood that we could impact by vaccines. And so that was my path to pediatric ID. It was George McCracken and John Nelson.
Wow. And so you went on to work with Dr. McCracken and Dr. Nelson in Texas. How was it to work in such a huge children's hospital with such huge eminences in the world of pediatrics?
So I went from Cincinnati Children's Hospital to the University of Texas Southwestern to be a fellow of George McCracken and John Nelson after residency in Cincinnati. And it was amazing. It was amazing on one respect because Heinz Eichenwald was still there at that time. And so I can remember some of our initial infectious diseases morning reports where we talked about children with what we then called aseptic meningitis, which really was a variation of a number of different enteroviruses. But always Dr. Eichenwald would bring up polio, and Dr. McCracken would say, we've cured polio. Now we're talking about enteroviruses as we spoke about those children. So it was energizing. It was amazing. They were remarkable mentors. And during the time that I was there as a fellow was when the infectious disease, the Pediatric Infectious Disease Journal was first launched. And so my instructors, my mentors in writing up research were George McCracken and John Nelson.
Wow.
Interesting.
Well, they are phenomenal human beings. I once asked Dr. McCracken if we're supposed to give steroids before you give the antibiotics and meningitis, pneumococcal meningitis, for those of you who don't remember that horrible disease. He said, yes. I said, why don't we do it interarticularly, just like we do for the cancer patients? And he giggled. This is in Washington Hotel. He giggled. He says, that's an excellent question, Herb. And I'm like, oh, maybe I'm going to get a fellowship with him or something. He goes, I did that. I think he used a rabbit model for meningitis.
Yeah, he had a rabbit model for meningitis.
I did that in the rabbit model, and every rabbit that I injected with steroids directly into their CNS died soon thereafter.
Oh, not a good
So
idea.
it's a great idea, but I suggest you never bring it up again. But he was so gracious. He was giggling and laughing, and it was just like, I thought of that idea too. It's a great idea, but it doesn't work. So anyhow, George, you had the pleasure of encountering measles when measles is not a disease that we see anymore. You were a resident in New York City?
I was a resident in Jersey City Medical
Jersey City.
Center.
What year was that?
Oh boy, 1993.
19.
If you look up and do a Google search, there was an epidemic, a mini epidemic in Jersey City, in New Jersey. It started at Rutgers University, I believe. We were admitting these children with, I remember that we used to call it hyperpyrexia and rash. That was your diagnosis. So a lot of fever with the rash. Kids were miserable, dehydrated, just irritable, more than just a fever, right? So they'd get admitted, give them supportive care, IV fluids. I don't remember what else. Did we do anything else? Did we give them just the coverage? I don't remember. Anyway, so they'd be admitted. And then I'd work in the emergency room. Some of the kids were really sick. Some of them were not so sick. They'd get discharged. And then one day, as an intern, I was having a fever, of course. And I go to work. And then I just like passed out. And then I had the classic, it looks like paint dropped onto your head from head to toe, rash, conjunctivitis, cervical nodes, coughing, fevers, 105. You know, I'm in the adult, they take me to the adult side of the ER, and they're looking at me like I have some Ebola virus or something weird. Nobody knew what it was, right? So it's sitting there for hours, IV fluids, and nobody knew what I have. Then they're talking, maybe we'll do a spinal tap, we'll start antibiotics. And then we had some of the residents that were around, and they heard I was
George, did you have photophobia?
No.
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 Did you have diarrhea? Do you remember?
No.
No. Okay. And so then no one knew, and then your pediatric residents came to visit.
They came to visit to see what's going on, and they said, "Oh, you look like all those kids were admitting on the floor." And then they told the adult medicine, and they did titers, and of course it was measles. Now, why did I have measles? Interesting. I got my measles vaccine, but I was of the generation that could have had one, but should have had two. And then when they do, you know how you do for nursing school, medical school, you have to get the vaccine titers. Of course, I had vaccine titers done on July 1st. And it was a 4th of July weekend when the results came in, and somehow, you know, the folder got closed. Nobody noticed that I had no titers to measles, and, you know, sent me out into the world to cure measles. I got sick.
And how long were you out of work?
I was out for 2 weeks. I was admitted for about a week. And you know, I do remember being in the hospital. You know, they give you IV fluids and you're just thrown in the bed somewhere. but like even like with COVID, it creates this thick membrane inside your airways, and I think that's what creates the respiratory distress, because you can go and just like pull it out of your mouth, out of your throat, just thick exudates.
Were you
And I got bitter,
miserable?
of course. Was that?
Were you miserable?
I was very miserable.
Very
I
miserable.
was
So
very miserable.
it's not just a cold.
It's not just a cold. And then to add insult to injury, what happened is I think I was vomiting, right? And I was vomiting a lot in adult medicine. What do they use for vomiting? Compazine. And what do you think happened with that? The idiosyncratic reaction of the compazine, where you're mad as a hatter and you're all hyperactive and you can't see. And, I remember my brother was a teenager, and I was still fresh off the, USMLE board. So I knew these things. And can you look up, what does compazine do? He looked it up in the book, and the kid is 15 and he's reading it. He says, "Oh, that sounds just like you."
Wow.
Yeah.
So Dr. Bravo, one thing that's interesting about the story that you alluded to, and I'll just comment on with another personal experience. So I'm the oldest of 5 children. I was born in 1953. I did have measles, as did my first 4 siblings. One of the most common and unique features of measles was photophobia. And I can distinctly remember being in my living room and my mom making sure that all the blinds were closed. And of course, I was the index case and spread it to all of my siblings.
Right.
But it's important to think about in terms of measles, because there are 5 reasons why we are going to continue to see measles across the world, and including within the United States. It's really difficult to recognize in the prodromal stage, because the prodromal stage is all fever, and nonspecific fever doesn't clue you into the diagnosis. The way measles looks typically is ratcheting fever for the first 4 years. And then by the time the rash has onset, the fever actually has disappeared. And so that makes it a very difficult diagnosis, unless you're a savvy clinician and you recognize the rash, which starts at the head and works down from the body, and then the association of cough, coryza, and conjunctivitis. The second piece of why we'll continue to see measles is that the herd immunity threshold is at least 94%. That's required to prevent transmission. And we're always going to see, I think, pockets of unimmunized or under-immunized individuals. So then the third reason is, by the time you do diagnose measles, it's already spread to the susceptibles. And of the susceptibles, 90% will develop disease. And it's just, if you think about the fact that it's globally still very prominent, it's just a plane ride away. And within the United States, the 5th important reason is that we have many states that allow personal vaccine exemptions, and there are hotspots for vaccine preventable diseases like measles around the country. It's just very, very fascinating to consider the fact that we'll still see this disease.
Yeah.
I remember in Costa Rica, in the pediatric ID ward, they were always so concerned about dehydration for these kids. And that's not in the textbooks, but they did get severe diarrhea. And if the measles didn't kill them,
correct.
the diarrhea killed them.
Yes.
And that's much worse in the underdeveloped world, where you don't have rapid access to pediatric hospitals, IV fluids, so on. But diarrhea was a real killer of kids with measles. And before measles vaccine, a couple of million kids or more died every year across the world from this disease.
And I'll just add to that. Measles infection increases mortality for all infections. The virus destroys our immune memory cells. Measles virus destroys immune memory cells, and that immune amnesia lasts for 2 to 3 years. So all-cause infectious disease related infections and mortality goes up. And
Wow.
that's irrespective of the last feared feature of measles, SSPE.
So what was SSPE?
So SSPE is a neurologic progressive entity that is inevitably fatal, that occurs 5 to 10 years after recovery from infection. So imagine you're an individual who survived this infection, which most children did, not all, but most children did. And for those particularly under 1 to 2 years of age, 5 to 10 years later, because of a persistent presence of this virus in the central nervous system, you present with this progressive neurologic disease that starts with cognitive decline. It progresses to seizures, it progresses to muscle spasms, eventually to coma, and inevitably to death within months to just a year or so. It is a devastating entity that we continue to see now, uniformly fatal.
So it's 100% fatal. You get symptoms 5-10 years after your measles infection. In 6 months, you're gone, and there's nothing that we can do for you.
Absolutely correct. And this is a vaccine preventable infection.
What a horrible moral injury to a parent that chooses not to vaccinate and lose their kid this way.
Yep.
Well, how horrible.
Yeah, I remember those kids when they were admitted, they had fever, but you know what? They had a fever of 106, 105, consistently 105, 106. It was like crazy fevers, and nothing would bring it down.
And these are kids with this measles infection. So when they initially present, this highly febrile phase of the illness might be the only thing that you see, and you can't see the rash, cough, cries, and conjunctivitis until that kind of 2 to 4 day mark. And then one more point, remember what we used to always look for to diagnose measles?
Koplik spots.
Complex spots.
Bingo. But guess what? In current kids, we don't see them quite as often. And oftentimes, by the time the rash comes, the Koplicks have disappeared. And so we look and look for them, or although we try to look for them, because you know how miserable children are with measles. And so to get into the mouth to try to look for these spots opposite the molars, it's really hard to do. But many times, by the time you really are kind of starting to understand what this febrile exanthem is, the Koplik spots are gone.
And so this sounds also very much like Kawasaki syndrome. High fevers, conjunctivitis,
yes.
and you had a pearl at the meeting of what to look for in the conjunctivitis that tells you whether it's Kawasaki's or not. What do I look for?
That's a great point. So within the differential disease of Kawasaki disease, it always is measles, and your clue there is vaccinated or not vaccinated for the most part. But as you're thinking about Kawasaki disease, we're looking for rash, we're looking for extremities, we're looking for oral findings, we're looking for lymph nodes, we're looking for the eye findings. So the limbic sparing of the conjunctivitis is what you're looking for to differentiate Kawasaki disease from measles. So the limbus is avascular, which means that the conjunctival injection for Kawasaki disease, because it is a vasculitis, extends up to the limbus and then stops. And so again, this is an entity where children are very, very irritable. And if you can have them at least looking sideways for you, where you can look for the limbus, if it is limbic sparing, think KD. If it's not, you're going to inquire about their vaccine status for sure. And then there's a long list of entities that are in that measles diagnosis differential.
That was a great pearl at the conference. Thank you so much for that. So the wonderful part that people forget is, of the past 75 years, our forefathers have made such advances in what pediatric healthcare and health is. And people have no idea of the sacrifices these men and women did and the sacrifices that the children made to make this day possible. So the first vaccine for measles was the Edmundston vaccine, terribly toxic vaccine. It gave you fevers higher than the disease itself, but you wouldn't die from measles later on. It was so bad that, and that's why I had this book here. So this book is written by Saul Krugman and by Dr. Sam Katz. So they want to study the measles vaccine, and they were giving kids immunoglobulin before they gave that measles vaccine to minimize the side effects of the vaccine. And they found that unacceptable. And with a third year of immunizations, Maurice Hillerman, they developed a new strain. And that's the Merck vaccine, the one we use now in the MMR. And universally, that's the one that's used, or the MMRV. However, there's some interesting steps in the way. So before that, there was a third vaccine that was so horrible that was taken off the market in two weeks. And there was a second vaccine that maybe George had that second vaccine that was approved early on in the 60s that it was immunodeficient.
That's probably it.
So it was well known that if you're vaccinated with not the Merck vaccine, but the other vaccine, you were at risk of having infectious measles later on in life. And that's probably what happened to you.
I wonder, why did they have that statement for school? If you were born before 1957, you didn't have to get the measles vaccine.
Perhaps everybody had it by then.
Maybe.
Yeah, but that's a very interesting, that those were the three vaccines that came out. And another fun fact is, I didn't know this, but chickens get leukemia, and it's a virally induced leukemia. And Maurice discovered this in his farm. He was actually a veterinarian, and then developed with Merck the first vaccination against cancer, which wasn't hepatitis B or HPV. It was a chicken cancer vaccine, because he needed the eggs. Because if you remember, the MMR and the influenza vaccine need eggs for production. And he was mortified that if you used egg to produce these vaccines that you're going to inject to children, and the leukemia virus from the chickens was in the embryo, that you were going to pass it on to humans. So there was a lot of really smart people and a lot of sacrifice, because there are some children that died during these vaccination campaigns, because we didn't know enough.
Yeah.
We had to immunize somebody to see if it worked or not. And on the other hand, there were children that should have received the vaccine that never got it because it was experimental. So they just got to suffer the disease. But it is a very interesting history of how we came to the measles vaccine and how we don't see this anymore.
There are, however, no children who died of cancer related to vaccine administration. And I guess it emphasizes the fact that as we introduced vaccines to the market, we looked at them very carefully. And those that did not produce immunogenicity or were not safe were removed fairly quickly. The first killed and first killed measles vaccine, and then the Edmundston strain vaccine did not last very long before we got a very effective product, both immunogenic and safe, that effectively prevent measles.
And long lasting, right?
And long lasting, exactly correct.
You get vaccinated, you're pretty much guaranteed you're never going to have measles.
Right.
I mean, they're miracles of the modern world. It's, we talk about all these tech innovations, but these innovations had a far-reaching effect in humankind. It's just amazing. I want to cry when I read these textbooks. I do. It's just, the things these people did, they vaccinated their own children. They went to prep schools, and they did so much for humanity. And we don't tell their story of how great they were to do all of this. So, George, I'll turn it over to you to ask me a few questions.
Ask you questions. Okay. So I heard that you know a little bit about the varicella disease.
So not much, but my my first encounter with varicella was my younger sister. I was in medical school in Costa Rica, and she developed this high fever, and then she developed this little blister. And my dad is like, "Well, you're in medical school. What's wrong with her?" I'm like, I don't know. So I called my good friend, was a year ahead of me, and a very smart guy, he's now an infectious disease person in Miami. And he walked in, and he goes, "Your sister's got chicken pox. Why can't you tell that?" I'm like, I don't never seen it. So that was my first experience. She was a teenager in high school.
Right. Do you have,
My
a personal, you have a personal experience on this?
Yeah, well, I have 3 stories. My
Oh, okay.
second was the panic with Dr. Odio, because Dr. Odio also worked in she worked very close with the hemo-oncology group at the Children's Hospital in Costa Rica. Because, as we alluded to before, 80% of kids with leukemia back in the early 80s and died, and mostly from complications of infection or bleeding. And she had this big clinic, or they had this big clinic, and she was their consultant. And inadvertently, somebody brought a kid with chicken pox to the clinic. And we'll ask, we'll talk about that more for a minute. And what I remember the most is her panic. I was too young to understand, I had no experience, but her panic. And I was in Costa Rica from 83 to 89. So this must have been, there's the later part of that. The Japanese had the Osaka vaccine, but the Americans were just studying it through Merck, and it was not available. The studies were being done to be careful to make sure that it was safe and effective. And they had some of the vaccine through Dr. McCracken because they were studying whether it was safe to use or not. And I remember her just picking up the phone and saying, "George, I have this." And him going, "Let me talk to Mark." And then by later that afternoon, all the kids that had been sitting in that clinic had received Visig and the experimental Merck varicella vaccine. Little did I know then, because I didn't have the experience, that that likely saved all of their lives. And the third experience that I had with chickenpox, when I was already in private practice as a pediatrician, one night I developed 103 fever. And then my stomach started itching, but an itching like I've never had before. It was just, I scratch, it wouldn't go away. I got up, I was all miserable. I went to the mirror and there was one pox. And I called the interners, Dr. Henry, and said, "Henry, well, I think I have chickenpox." He says, "You cannot have chickenpox. You cannot get through a pediatric residency, all the varicella you saw in Costa Rica, your sister had varicella, and now be a pediatrician and have chickenpox. Go back to sleep and call me in the morning." By the morning, I had now 3 poxes, right? I had the pox, the one that eroded, and the scabs. And I said, "You better come by before you go to work." And he walked in, "Oh my goodness, you do have it. Let me call you some here." I spent at least 3 days in a Benadryl coma. I was so miserable. Nothing made me happy. It was such a miserable disease to have. Once the itching went away, I was out of work for 3 weeks.
Yeah.
I was in bed for at least 10 days. And then the other 2, all the poxes had not scabbed over yet. So I was infectious, so I couldn't see patients. It was one of the most horrible illnesses I've ever encountered.
Yeah, but there's other complications that you get. We had an intern that had varicella encephalitis.
Sure.
She was really, really
Yeah.
sick.
Yep.
The interesting thing about varicella encephalitis, the symptoms of encephalitis can precede the pox. And so it can often be a diagnosis that you don't know for 2 to 3 days. And in the pre-vaccine era, the problem was if you had a child hospitalized with encephalitis and they weren't isolated for varicella, you had multiple individuals coming into that patient's room and then possibly the spread. You know, it's interesting. Varicella was regarded when I was growing up and until the vaccine came as a benign and inevitable infection of childhood. There would be 4 million cases every year, 10,000 hospitalizations, 100 deaths. And it wasn't until 1986 or about 1990, and I think you both remember, where we saw what the lay press called flesh-eating bacteria.
Yes.
And there was a statistical increase in the severe skin infections caused by group A streptococcus, which was necrotizing fasciitis that occurred with toxic shock syndrome in many cases, that really led to finally the licensure of the vaccine. In 1992, my group here at Children's Mercy here in Kansas City published on the complications of varicella requiring hospitalization in previously healthy children. And you'll be interested to know, while common skin infections were on the list, Benadryl coma was on the list too. Their overdoses of Benadryl in that population. Varicella encephalitis certainly was well described, but it wasn't until we really started seeing those complications that were life-threatening and occurring in outbreak fashion that we finally, on St. Patrick's Day in 1995, had the licensure of our first varicella vaccine.
Right.
And it was Ann Gershon's lab that had done all of the previous research to show that it was not only safe in the otherwise healthy child population, but could be safe in other populations too.
Now, for the medical students that listen to this podcast, what about that Ray syndrome? I've never seen that. I know about it from the USMLE, and that's about it.
So Rye syndrome definitely was something, and in fact, the association of Rye syndrome with influenza and varicella was highlighted in the late 70s and early 80s. It was when I was a resident at Cincinnati Children's when we started seeing a number of cases, and Bill Balistreri, who's kind of the great grandfather and pioneer of pediatric hepatology, was there with us. And we identified these cases where children presented with intractable vomiting and then coma, and there was very little we could do to support those children. And so there were quite a number of deaths. There was the CDC studies that showed an association between influenza and or varicella plus aspirin exposure.
Yes.
And that's why we do not give aspirin to children any longer, although there's some question now as to whether aspirin was really the culprit or whether or not there could be a genetic